Good evening, sir. Good evening, all participants. Today is our 31st case meet. It's in honor of our Platinum Jubilee celebration of ISA National and our Silver Jubilee celebration of our City Branch Nanded. We are conducting this case meet weekly, Friday at 8 p.m. as usual. Today's our guest speaker is Dr. Umesh Gopanwar, sir. He did MBBS from KMC Mangalore and he did MD from AIMS. Sir is a professor and head department of neuroanesthesia from at DIMAS, Dharwad. Sir has published almost more than 100 publications in depth journals, and important publications are perioperative investigation. This is today's topic: practice guidelines from the Indian Society of Anesthesiology. It is a multicentric trial, and sir did very wonderful job, and 500 downloads happened on this topic till now. 5,000, sorry. And perioperative fasting and feeding in adults. Yes, sir. 6,000 now. Very great achievements. Perioperative fasting and feeding in adults, obstetric, pediatric, and bariatric population. Practice guidelines from the ISA. One of the best and unique things, sir, did Umesh intubation detector for rapid and reliable identification of tracheal intubation by no ISS in anesthetized, paralyzed adult patients. One of the most important next thing is pre-oxygenation with 20-degree head up tilt provides longer duration of non-hypoxic apnea than conventional pre-oxygenation in non-obese healthy adults. These are the sir's important publications. Sir, once again, welcome you on this platform, and from ISCCT branch, all members welcomes you. Sir, now you can start your screen sharing. Its screen is yours only.
Thanks. Thank you, sir. Thank you very much for kind introduction.
Thank you, sir.
Sir, need to stop sharing the screen, then I can.
Yes. Dipen, please allow sir screen sharing.
Yes, it's allowed.
Okay. But it's still saying you cannot start screen share while the other party is sharing. Actually, my CV is being projected. If you can stop it, probably I think I can share from then on.
Yes. Dipen, please look into it.
So you are allowed. Just try again.
No, it's not possible. I'm getting the same message. Yeah, now it is done. Yeah, I will do now.
Yeah. Okay, sir. Thank you.
Thank you very much. Can you see the screen that I have projected now? Sachin, sir? Hello?
It's visible now, sir.
No. Visible, no? Yeah, okay, right. Yeah,
yes,
thank you.
Yes.
I'm audible clearly, no, sir?
Yes, clearly.
Okay, right.
Clearly.
Yeah, okay. Fine. Thank you very much for kind introduction, Sachin, sir. It's indeed my privilege and pleasure to participate in the Maharashtra ISA City branch meeting. I'm really grateful for giving me this opportunity. The preoperative investigations guidelines was actually a vision of Dr. Balabhaskar S. So he wanted to make national guidelines in this regard, and then we decided as to why to go about doing these guidelines. And then finally, once we were convinced that it is worth doing this exercise, we decided to make evidence-based guidelines. So the end result of that is what I'm going to share with you today. Yeah, first of all, we need to ask the question as to why do we need guidelines? Now, we know that already USA, UK, some of the European countries and many other countries have already brought preoperative investigation guidelines. Now, why do we need a separate guidelines for our country? That is a question that we need to answer, and we need to be convinced that yes, it is worth guide for our, then only we can try and proceed further. So first and foremost fact that comes to our mind is that India is such a vast country with such a different population. socio-economic and cultural aspects, they differ from region to region. So we have setups, something like, a primary healthcare setup where surgeries are being done and anesthesia is being provided. We have some small, tiny nursing homes where there may be only one surgeon who is one surgeon and one anesthesiologist involved, to tertiary care centers and corporate setups. So with such a wide options that are available across the country, we felt it is important to bring down, a set of investigations that are essential for all the patients, so that everywhere they can be practiced uniformly across the country, one nation. Now, to do that, we did have certain hassles. One of them, major hassle, is that we have private practitioners. Now, if we bring down guidelines suggesting that, such and such investigation has to be done, then mandatorily it needs to be practiced. So we need not, we had to keep in mind private practitioners and the medical legal hassles that can be involved in these things. But at the same time, we did not want to sacrifice the evidence basis. So we tried to first synthesize the evidence base, and then we wanted to see whether this can apply to our nation. And thankfully, most of it is applicable to our country as it is, as per the evidence. So in the subsequent slides, I'll discuss about these things. So as I told you initially, the formulation of ISA guidelines was actually a vision and a proposal given by past president of our ISA National, that is Professor Balabhaskar S, who is from Ballari in Karnataka. And because of his vision and his pursuance with then President and Secretary of ISA somewhere in 2018, finally a roadmap was prepared for making 5 different ISA national guidelines. Preoperative investigations was one among them. To oversee the progress of these national guidelines, a core committee constituting 7 members was made. And for each guideline, core committee selected a set of experts from across the country who were academicians in the field of anesthesia. And these experts, along with the core committee members, framed important research questions to that particular guidelines, and based on those research questions, keywords were selected, and then literature review was done, and with the selected articles, appropriate systematic review was done, and where applicable, meta-analysis was performed. And as the end result of all this hard work will be the guidelines. So the core committee consisted of the 7 members who are listed on the left side of the screen, and it also has on rotation basis the current president and secretary, whoever is there in position at that stage, as honorary members. The expert committee for preoperative investigations, we tried to include well-known academicians from across the country representing different parts of the country. So there were in all total 16 experts from the field of anesthesia and 1 biostatistician to look after the statistical aspects. So this guidelines are finally published in the year 2022 in the month of May. The guidelines that we have read are applicable to only a certain subset of patients. That is, ASA physical status 1, 2 patients who are scheduled for elective surgeries, not applicable for emergency surgeries. They are scheduled for elective surgeries, excluding specialty surgeries such as neurosurgery, cardiac surgery, thoracic surgery, vascular surgery, or organ transplant surgery. Specialty surgery has specific organ involvement and special investigations done related to that particular organ system. So what we wanted was to bring down uniform applicable guideline practice, investigation practice across the country for general surgical population. So that was the goal of this particular guideline development. And the main objective was to recommend minimum required set of investigations that can be uniformly applied as a starting point. Subsequently, the anesthesiologist should decide on additional investigations based on the patient's pathophysiology. So the main outcomes that we wanted were influence these investigations in the immediate operative outcomes, it should determine anesthetic management. In the sense, either general anesthesia or regional anesthesia can be determined based on what investigations reports have come. The monitoring parameters in the operative period. In some way, it will influence anesthetic management. Only then such investigation will be considered as a routine investigation to be applied for all population. Applicable to age one patients, just uniformly age physical status one patient who don't have any comorbidities. These investigations, by and large, will be applicable to them as a rule of thumb. But they may be having certain addictions or a surgical procedure. Again, based on evaluation and a review of the medications plus any additional any additional investigations to be done, it is left to the discretion and judgment of the anesthesiologist who is attending to the case. Now, when it is ASA physical status 2 patients, these same attending how far a person is being affected, they decide additional investigations. Now, these are applicable to three, four patients not fit to undergo surgical interventions. So what usually happens is referring such that is status 5 patients to some physician, some individuals take care of the patient and optimize them because they are deemed fit to undergo anesthesia elective procedures, and therefore they determine additional investigations, how often they need to be done, and when the patient is optimized. Similarly, when it comes to emergency surgery, some of the emergency surgeries can be very be done after a few hours, but there can be some perforation peritonitis or bleeding where need to be done immediately. Now, it can be so limited where need to and the anesthesiologist has to send them and then it's not really appropriate. Therefore, we have left it discretion of the anesthesiologist and the surgeon involved with that particular emergency case to decide on what whether to arrive or proceed with the surgery, depending on the nature and urgency of the surgery and also the infrastructure involved. So the foundational idea was that it should not cause medical legal hassles to our practitioners, although we will be having evidence-based guidelines. Now, another important fact that we need to understand here is screening tests are not focus of these guidelines. As I told you earlier, the idea of these guidelines was with the objective of finding any change in the outcome in the immediate post-operative or perioperative period with the patient, or it should change the way we practice the anesthesia in some way or the other for the betterment of the patient care. However, when we ask for screening tests like HPSAG or HIV or COVID test, if the patient is generally asymptomatic and is fit enough to climb 3 flights of stairs without getting breathless, these screening tests will only help in probably safeguarding us, but not that will not affect the outcome of the patient in any way, or will not increase or decrease the monitoring that we need to do for those patients, and therefore we have not included these tests for guidelines. Also, pediatric, bariatric, and obstetric population, they differ in their physiology considerably to general surgical population, and therefore they have their own associations, and we need to respect that, and guidelines that are brought from those particular associations will need to be now, the inclusion criteria included all the studies that were done or published between January 2010 till November 2010, and wherever full text English articles were available, all these studies were taken into consideration. While meta-analysis, systematic reviews, and other studies which were available, other articles other than studies, if they are available, we screen them for relevant studies and try to include them also. Now, studies should be include patients for elective surgery, going the specialty surgeries, which I told you already. They have to clear medical status. There were several studies which were done by surgeons where ASA physical status was not mentioned. So because of that, some we have separate data available for ASA physical status unattended patients. In such cases, these were guideline solution. Now, if a study was done on preoperative investigation with the outcome as only cost analysis, but not outcome about the patient or related to change in the anesthetic management plan. If only cost analysis was involved, such studies exclude from considering for systematic review. Now, studies that did not mention ASA grading, as I told you earlier, and also studies where surgeries were excluded. Now, finally, the core committee prepared about 10 research questions, and they were called draft research questions. And then each research question was allotted to a set of 2 or 3 experts. Now, these experts again refined the research questions, and final 10 research questions were made. Now, a group of 2 or 3 experts collected all the literature evidence available related to that one specific research question, and they made a systematic review out of it with the help of the core committee. Once a systematic review was finalized for one particular research question, we presented it to the statisticians and had a discussion with the statistician if meta-analysis could be done in that regard. Unfortunately, for our preoperative investigation guidelines, all the studies that we had were retrospective or prospective observational studies or case cohort studies, but we did not have any randomized controlled trials, and therefore a proper meta-analysis was not possible. Plus, also the outcomes when they were assessed, some of the studies, they had, say, for example, 1,000 patients were included for the study. Out of them, some 700 patients had investigations done. Now, what happened to the outcome of the other 300 patients for whom these particular investigations were not done? That was not available in the studies. Plus, in those 700 patients, there may be an abnormal report for 100 patients. For another 600 patients, the report was normal. Now, again, the outcome of those 600 patients whose reports turned normal was not mentioned in most of the studies. Only they concentrated on those 100 investigations which were abnormal, and then they have given conclusions as to whether that influenced the outcome of the patient or anesthetic management. Because of these limitations, the meta-analysis was not possible in this particular guideline. Now, finally, we followed the grade protocol for the preparation of guidelines. This is something new for us Indians who have not been involved in systematic reviews and meta-analysis. So we actually consulted the father of this grade protocol, which is Dr. Gordon Gayat from Canada. In fact, he was kind enough to give us 2 meetings of 1 hour each. So once we prepared the systematic review and we prepared draft guidelines, we presented it to Dr. Gordon Gayat, and he went through all of them, and he gave very valuable inputs as to how the final guidelines should come out, and based on his inputs, final guidelines were made. Now, one of the major hurdles that we faced while preparing the systematic review was that different kinds of surgeries included different studies. So, surgeries, we had to determine them whether they are simple minor surgeries or they are sort of intermediate surgeries or major surgeries, without which it was difficult to give a blanket kind of guideline as to whether a particular test is needed or not. For example, let's say liver function test. Now, liver function test, if we do for a patient who is undergoing it is used, but at the same time for surgery very very much essential. Now we need to have that kind of categorization. For that reason, we just literature if any clear cut categorization of surgical procedures was done, and unfortunately there is nothing like that. Only the National Institute of Clinical Excellence, NICE from United Kingdom, they have categorized on the premise that the more the invasiveness, more will be the stress on the patient, and based on that, with some examples are minor, intermediate, and the third category is major or surgery. They have not given any reference on how, on what basis they have to give that. So instead of copying that, we decided we will do it ourselves for our country. So what we did was a core committee gathered about 40 to 50 commonly performed surgical procedures across India, and then we made a Google survey which was anonymously given to each of our subject experts. All the 16 subject experts, they were requested to categorize particular surgery into either it is minor or intermediate or major. And then we took the consensus among them. If 12 or more experts out of 16 experts agreed that a particular surgery should be categorized under a particular category, then only that was taken as an example. Where there were about 5 or 6 surgical procedures where we did not reach consensus, so that we have not given here as example. So this list of surgical procedures this was formed based on this systematic review, and then the guidelines were prepared. So to arrive at recommendations, we have because of towards the end of 2018, we started with these preparations, and in the year 2019, and for the deadline, so we platform. Subsequently, after about probably around 1,500 to 2,000 hours of things between the core committee and then with the experts and the biostatisticians and including with Dr. Garden Guide, we arrived at the final recommendations. Recommendations were based on the grade protocol as suggested by Dr. Gordon Guide, where we had a high more than one and therefore the we recommended investigation, where the level of evidence is very low. It is considered as a weak and therefore the term suggested will be used. Because we did not have any RCTs for the preparation of these guidelines, all our evidence was low. For all recommendations have used the suggest. So finally, we made draft recommendations. So it was 7 core two to three. Those 9 or 10 people had detailed analysis of the systematic review, and then based on the available evidence, we formed a draft recommendation. We could have finalized that recommendation, but when we do that, we could have
Sir, please unmute yourself.
audible. Sir, am I audible? Hello.
Hello.
Yes, sir. Am I audible?
Yes, yes.
Okay, fine, sir. So at the end of DELPHI consensus, all the experts agreed about these recommendations after debating about certain recommendations. So finally, once all the experts agreed, we finalized the recommendations. So now I will go through each of these recommendations. The first research question was related to complete blood count. In ISA physical status 1 and 2 scheduled to undergo elective surgery will routine preoperative complete blood count testing. This was the research question. So when we collected evidence related to complete blood testing, we two sets of data. Some of the studies had done CBC as a whole and reported the data, while some studies have considered component CBC as hemoglobin, total count, platelet. So we were kind of confused as to what recommendation to give for component CBC as a whole. So we did the nationwide survey among practicing anesthesiologists from ISA. Overwhelming majority felt that they would rather order CBC as a whole rather than individual components. Plus, because of the advent of auto analyzers, which are available now almost in primary healthcare centers also, even if we ask for only hemoglobin, we get a CBC as a whole. And therefore, the recommendation was for CBC and not for individual components. Now, the recommendation is preoperative complete blood count testing is suggested for patients undergoing all kinds of elective surgery, whether it is minor surgery or irrespective of the nature of surgery, wherever physiologist is very clear that intermediate and CBC was necessary, but it was not so clear regarding minor surgeries. But when we try to see the incidence and prevalence of anemia in the preoperative population scheduled for elective surgery in ASA physical status 1 and 2 patients in India and in the Indian subcontinent, we found that in India it was more than 14%. The prevalence of anemia in pre-op population that is scheduled for elective surgery. And because of that, we decided to order CBC also for minor surgery also. Now, regarding renal function tests, mainly we have blood urea and serum creatinine as part of renal function profile. But blood urea may be altered when somebody is dehydrated, urea levels will go up, or if liver function is affected also, the blood urea may be affected because urea is synthesized in the liver. And therefore, we consider serum creatinine as a better predictor of renal function. Also, estimated GFR also takes into account suggested. So when we had a data of around 2,000 odd patients who are undergoing minor surgery and for them serum creatinine was done, there were about 15 to 8 patients who had serum creatinine in the range of 1.9 to 2.1. However, they were completely outcomes for the anesthetic management were not influenced because of that derangement. So that's the recommendation. But patients who are under intermediate and major surgery, serum creatinine is suggested to be done preoperatively. In serum electrolytes, mainly we do serum sodium and serum potassium, and literature was also made available for serum sodium, and few others were available for serum potassium also. So the recommendation is preoperative serum sodium and potassium estimation is not suggested for patients undergoing any of these surgeries, elective surgeries. Now, when we say it is not to be done, that does not necessarily mean that the anesthesiologist should blanketly it may be an ASA physical status 1 patient completely fit and healthy, but is scheduled to undergo transurethral resection of prostate. When this surgery is being taken, you know that there will be irrigation fluid that is given, maybe glycine or water or some other solution, and quite a lot of that will get absorbed. And there is a possibility that patient will go into hyponatremia in the intraoperative or postoperative period. And therefore, in such situations, the attending anesthesiologist should take the liberty to order preoperative serum electrolytes. Similarly, if a patient is on diuretics or a patient is on angiotensin receptor blockers or some other medication which influence the serum electrolyte value, in such scenarios, the attending anesthesiologist should order for these investigations. So we leave it to the discretion of the anesthesiologist wherever necessary. Regarding liver test, very clear. Preoperative liver function test was not suggested for patients undergoing minor going surgery. There was no in the literature in this regard. It was very clear. Now, regarding the coagulation profile, although when we were doing post-graduation, bleeding time, clotting time were considered as coagulation profile, now with the availability of auto-analyzers, coagulation profile largely means prothrombin time, international normalized ratio, and APTT testing. And so we consider these as part of coagulation profile. Now the surgery. I would re-highlight that necessarily for coagulation no to coagulation profile. If we want to practice a regional anesthesia and if the patient is on some of the medications, whatever, if that may influence the coagulation status of the patient. So based on history, clinical evaluation, and the medication the patient is on, the attending anesthesiologist should coagulation profile if necessary. So for that, we can refer to the existing guidelines related to anticoagulation and regional anesthesia. Now, blood glucose is something which is a very debatable topic. Now, see, if a patient is diabetic, there is no doubt that preoperatively blood glucose needs to be done prior to surgery. However, what if it is a non-diabetic patient? What is a non-diabetic patient? It's a ASA physical status 1 and 2 patient who is scheduled to undergo elective surgery. But when you evaluate the patient by history, clinical examination, or by considering the medication or previous reports of the patient, nothing that is suggestive of diabetes mellitus. In such patients, if we do preoperative blood glucose estimation, are we justified, or will that really influence the patient outcome or anesthetic management? So what we found was that in non-diabetic patients, preoperative blood glucose estimation is not suggested. It is not going to make any difference. See, if a patient is having hypoglycemia, symptomatic, and then we can do the investigation. If the patient has a mild hyperglycemia, something like in the range of 120, 150, 160 blood glucose, it is not going to adversely affect the perioperative outcome or the anesthetic management. However, if somebody has a blood sugar above 300, 400, obviously they will be symptomatic again. They already know diabetes. In such case, definitely the test will necessary. Research was related to early program. Again, if the cardiac patient, the patient has any history suggestive of either heart pathology or chronic disease, in such patients, definitely preoperative ECG is in cardiac patients. When we take proper detailed history and evaluate the patient and go through patient medications and previous reports, nothing is suggestive of cardiovascular disease. In such cases, are we justified in doing 12 lead electrocardiogram in the series? Cardiac 12 lead electrocardiogram testing is suggested at age of 45 years and above when scheduled to undergo minor surgery. Actually, the evidence base suggested that it may not be necessary to do even in patients above 45 years. But as a rule of thumb, most of us are practicing ordering ECG at the age of 45 years and above. And when we went through the prevalence of heart diseases in India, astonishing evidence was available that India is going to reach to patients 45 years and above. Considering that strong evidence, decided to suggest PhD for all patients above 45 years, irrespective of minor or intermediate surgery. Or if a patient is scheduled for major surgery, evidence is clear that yes, ECG needs to be done irrespective of the age group of the patient. Nowadays, so do not take to do, and some of the yeah, because it is endemic to tuberculosis, we have so much of pollution in the cities, and in addition, active and passive smoking is so common. Definitely, there will be cumulative effect of all these things as the age advances, and therefore, at some stage of life, when we do a chest X-ray, obviously there will be some minor findings in the X-ray here, and maybe there is increased bronchovascular marking. There may be a small amount of effusion or some other pathology may be detected. But if you evaluate the patient, Sorry, there seems to be some disconnection in between. Apologies. Recommendation for that suggested patient undergoing minor surgery if the patient is asymptomatic at this undergo surgery. However, for patients undergoing intermediate and major surgery, we did not have a very clear evidence to what age is appropriate. So we took expert consensus through DELPHI consensus, and preoperative chest X-ray suggested for patients aged 50 years and above if they are undergoing elective intermediate and major surgery. That will be the recommendation. The ninth research question was related to ultrasonography. First question that we wanted to address was ultrasonographic evaluation of the airway. Can that be considered as actually a preoperative investigation or test? If X-ray and ECG can be called as test, why not ultrasonography? So based on that premise, we decided to include ultrasonographic preoperative airway assessment to predict a difficult airway, specifically difficult laryngoscopy. Now we had 22 studies available for ultrasonographic airway evaluation, and 20 of them indicated that ultrasound is a better predictor of poor Cormac-Lehen view on laryngoscopy. However, we did not have a very, each study had given a certain parameters as useful. Now, if you take all the 20 studies, we could not come to consensus to say about 2 or 3 important ultrasonographic airway parameters that we can consider as, definitely relevant in predicting poor laryngoscopy view. And in addition, ultrasound is coming up field in India also now. Most of the suggested because it is not available at financial the location is there in every theater free of evaluation. It may not be available. Consider all that, and that it is a field next 5 years probably a clear cut parameters to evaluate. Current suggestion is that it is not suggested for difficult laryngoscopy. The last of it is regarding validity time for previously performed investigations. So when we say validity time, just clarify. Suppose a patient comes to you for in a preoperative pre-anesthetic clinic, and you see that X-ray, some of the blood tests done. Now, should we repeat it for the purpose of surgery or not? If we want to use the previous investigations, how long are they valid? This was the question that we wanted to address. And in fact, of all the guidelines on pre-op investigations that are available across the globe, this is the first guideline which has come up with ultrasound evaluation for preoperative airway assessment and the validity time. So we feel really happy that we have taken something in addition to what is already available, and we could come out with very clear suggestions for this also. So the recommendation 10A is the acceptable validity time for a previously performed normal blood investigations is 2 months. That means if a patient has gotten blood investigations 2 months ago or less than 2 months ago, and his condition or her condition has not changed, one month old can be considered for the current surgical procedure, and we need not have to repeat it. But if the patient condition has deteriorated in this meantime, then a fresh investigation has to be ordered. Similarly, ECG and X-ray, up to 12-month-old ECG or X-ray, if the patient condition has not changed in the intervening period, can be accepted. With that, I come to a conclusion. Now, this particular table summarizes all the investigations and the guidelines. The green particular investigation surgery left side of the screen, and amber indicate that a particular test is not applicable to be done for that particular type of surgical category. So with that, I end this presentation. I'm really sorry, in between there was some disruption in the connectivity. Thank you very much. If you have any questions, even I will be available now for taking your questions, and I'll answer to the best of my knowledge and ability. Further, if you have any questions or clarifications that you need subsequently also, kindly feel free to contact me on these numbers. Thank you. Over to you, Dr. Sachin, sir.
Sir, thank you, sir. It's very nice talk, but somehow there is technical glitches, net issues, and audio was somewhat not able to hear some talk. But still, I will upload this video on our ISA CD Branch Nanded YouTube channel, and there will be, I think so, that it will be clear and loudly audible.
So
Sir,
this
thank you
presentation
for this.
also I will send to you. You can kindly share it
Yes,
with
sir.
your group, sir.
Yes, sir. Yes, sir. Definitely, I will share that also, sir. No issues. Sir, recent from guidelines point of view, it's a very basic thing that up till now, we Indian Society of Anesthesiologists, we don't have any guideline related to perioperative investigation. This one is the first step and a very milestone from our society, that our private forum peoples are somewhat worries about what to do and what not to do, and this guideline will be clear for us. Point of medical legal point of view, it's a very beneficial for us also. So it's a great thing, sir, you did, and your all publications also are very much good, and they are milestones also, because you did in peri-oxygenation, also pre-oxygenation in obese and other cases also, and your UID, intubation detector also. So you are doing a very wonderful job, sir, for our society and all our private.
Thank you, sir. Thank you. Sir, any
I will
queries
ask.
from the audience? I would like to take them.
Yes, yes. Uh, any queries? Please ask in question answer box, or you can speak, unmute yourself, and you can ask any question to Umesh, sir.
Please feel free to ask any doubts you have. I would be very happy to answer and share you number and the Twitter account also. You can ask me the queries that you have for any clarification. I'll be really happy to answer them.
In regional techniques, also you mentioned about APTT on INR. You should not do like that. That was the it's a controlled randomized trial. So is it how much helpful from your point of view? But these are the guidelines, and they are helpful always. But any in between your committee members, or think that it should be, or it's equal.
Yeah, we did discuss.
Yes,
Definitely,
yes.
there was a
So,
lot of deliberation on this, sir. Evidence is very clear. If you do
yes,
a
sir.
proper detailed history, clinical evaluation, and go through the current medications and the previous investigation reports of the patient, and none of that suggests any coagulation abnormality, doing coagulation abnormality is not really beneficial. However, if a is free to take additional investigations. So what all these guidelines are a starting point as investigations. They don't actually, help the practitioner that, okay, if I do only these many investigations, that means it is all right. Patient needs to be evaluated. Any additional investigations need to be done based on the patient's pathophysiology. They need to be done again.
Yes, sir. So one
But
question
by and
from.
large, for all ASA1 patients, this must be sufficient. Yes, sir.
Okay, sir. So one question from Dr. Supriya ma'am. For ASA grade 1 elective surgery for minor to intermediate surgery, does only CBC is enough?
Madam, Dr. Supriya, madam, am I audible? Sir, Dr. Sachin, am I audible, no?
Yes, sir. Yes, sir. Yes, sir. You are audible, sir.
Yes. Right. Sir, I would share the screen once more. Yeah.
Last screen is very much useful, bro.
Yes. Yeah. So for minor and intermediate surgery, actually we need to do complete blood count. For intermediate surgery, we'll be doing the renal function test. And for all patients above 5 years or above, we'll be doing ECG also. So all these recommendations are here. So if you have minor and intermediate surgery, we'll have complete account renal function tests that are mostly relevant. And for patients and above, even if they are having the no history suggestive of cardiovascular abnormality, and ECG needs to be done. And if they are above 50 years, for intermediate and major surgery, chest X-ray also needs to be done. Does that answer the question? If you still have doubts, please message in the chat box. Please this numbers, email ID or number, and you can always WhatsApp.
Sir, in some cases, there is a we feel that it should be done echo in major surgeries, and
Echocardiogram.
yes, sir,
Yes,
sir,
sir.
2D echo.
That is usually it is determined by the cardiologist rather than
Okay,
us.
okay,
We did
but
actually try to collect evidence for echocardiography, but in ASA physical status 1 and 2 patients, we hardly found anything that is addressing the issue of echo. And some of our experts did actually debate during the meetings that, after 65 years, and some said after 80 years, echocardiography should be mandatorily done. But then that was not evidence based, it was the expert's opinion in our group meetings. So we decided actually, ECG, we will give guideline. Regarding echocardiography, if we feel that there is any history suggestive of cardiac pathology, we will be usually referring the patient for a cardiologist, and they decide about the suitability of echo, TMT, and other things. This is
so
again to prevent medical legal hassles for our practitioners also.
okay. So you will say that we should send the patient above 45 years to cardiologist for this.
No, sir, no, sir, no, definitely not. If a patient
Okay,
has something suggestive of cardiovascular pathology or their ECG suggests some problem,
okay, okay. Then only you send to cardiologist, and that safe or echo is only cardiologist can decide, as you are mentioning like that.
that's how we assume, sir. It's not
Okay,
our only our opinion and consensus. It's not based. What we have presented till now is evidence based. Regarding
okay,
echocardiography, we did debate a lot. We tried to find evidence, but we don't have much evidence regarding
okay.
echocardiography. Because most of the times we just refer the patient to the cardiologist, and they decide on echocardiography and stress tests or even
Okay.
angiography.
Yes, sir.
But unless patient has a different history or clinical finding, we need not have to refer the patient to cardiologist for echocardiography, irrespective of the age.
Okay.
Like my mother is 73-year-old and she underwent a fracture femur surgery electively. She did echocardiography because ECG was longer.
Okay. Thank you. Thank you very much, sir. Am I audible?
Expected lot of interaction because of the problem of probably maybe the delegates could not
Some technical issues are there, sir. Your sound is not coming to me.
because from Maharashtra we really respect Maharashtra a lot. A lot of academicians and enthusiasts are there who very actively participate in these things. So I definitely had a lot of interaction. it's most likely because of the audio-visual problem, the technical issues that
Yes,
we had.
yes.
I don't know if
Yes.
they could really listen to all aspects of this presentation. I'm really sorry for
Definitely, sir. It will be even these things are recorded and downloaded on YouTube. So, and there is a lot of our
Thank
ISA private forum colleagues also, and medical student, PG students also are a subscriber of our channel. So they are watching regularly our channel. So it's very useful for in future also, not to today only.
Right.
And
Okay.
yes, sir.
I'll share the presentation with you, sir. You kindly forward it to all your
Definitely,
group.
definitely, sir.
Yes, sir.
Yes, sir. Yes, sir. Thank you. Thanks once again, sir.
Thank you very
Have a
much.
happy weekend, sir. Yes.
Thanks a lot.
Thanks.